Hello, my name is Dr. Andrea Wolf from the Brigham and Women's Hospital. I am going to demonstrate the proper technique for thoracentesis. We'll review the indications, contraindications, equipment, setup, correct technique, and potential complications of this procedure. Indications for thoracentesis include analysis of pleural effusion, treatment of pleural effusion. In settings where continuous drainage and/or pleurodesis is required, one should consider thoracostomy rather than thoracentesis. There are several absolute and relative contraindications to performing thoracentesis, which should be elicited from the patient's medical history and physical exam. A history of a bleeding diathesis, anticoagulation, relative and depends on extent, plan for other treatment in asymptomatic patient, for example, planning for diuresis in patient with congestive heart failure and bilateral pleural effusions. Prior pleurodesis or extensive surgery on ipsilateral side. This is a relative contraindication and can be safely performed by surgeon in certain circumstances. Lastly, in settings where the contralateral lung is compromised due to prior pneumonectomy or other mechanical or anatomic abnormality, a thoracentesis should be performed by an experienced clinician, as the potential negative consequences of a pneumothorax on the side of the well-functioning lung may be magnified. The chest wall consists of skin and subcutaneous tissues, intercostal musculature, ribs, and the parietal pleural surface. Intercostal vessels and nerves run laterally along the inferior margin of each rib. When performing thoracentesis, a needle is introduced through the intercostal space into the pleural space. Insert the needle on the superior margin of the rib to avoid the intercostal vasculature and nerve. The fluid is withdrawn from the pleural space, taking care that the lung parenchyma is not injured and air is not introduced into the space. We will now review the specific steps required for thoracentesis. It is important to elicit factors that predict difficult thoracentesis. These factors include use of positive pressure ventilation, mechanical ventilation, BiPAP, CPAP, in which there is increased risk of tension pneumothorax if lung parenchyma is pierced. The presence of cellulitis or other cutaneous lesion, which should be avoided to reduce risk of introducing infection into the pleura. Presence of loculated pleural effusions or pleural effusions in patients with prior surgery on the ipsa or contralateral chest, as mentioned earlier. It is important to have all the necessary equipment at hand before attempting a thoracentesis. The basic equipment needed includes pillow and table for patient to lean on, pulse oximeter for pulse and oxygen saturation monitoring, source of oxygen and delivery system, nasal cannula or mask, sterile gloves, sterile prep solution based in alcohol, chlorhexidine, or iodine, applicator or gauze to apply prep solution, sterile towels, 4 to 5, or a drape set, 1% plain lidocaine. 10 cc syringe times 2. 30 cc or 60 cc syringe. 27 gauge or 25 gauge needle, short. 22 gauge needle, long, for example, 2-inch. 11 blade scalpel with knife handle. 14 gauge needle. 18 gauge catheter over needle that can be connected to a 3-way stopcock. 3-way stopcock. High pressure tubing. 2 vacuum sealed 1-liter bottles. Several pieces of small sterile gauze, 2 by 2 inches squared. Occlusive dressing, for example, Tegaderm. Tubes for lab analysis, gram stain and culture, cytology, chemistries, cell counts. To prepare for a thoracentesis, take the following steps in advance of performing the procedure. The patient should have a physical exam and chest x-ray. If you question whether the fluid is free-flowing, obtain a chest CT or decubitus films with the diseased lung down to confirm layering of the fluid. Confirm the patient's platelet count is above 50,000 and that the PTT and PTINR are not significantly elevated. Ideally, anticoagulants should be held before the procedure. For example, intravenous heparin for 6 hours, low molecular weight heparin for 24 hours. However, anticoagulation is a relative contraindication, and the risks should be weighed against alternatives such as reversal of anticoagulation or delaying thoracentesis. Formally request the patient's permission to perform thoracentesis and ask them to sign your clinic's informed consent. The procedure risks are often explained during this process, giving the patient an opportunity to ask questions. Arrange for an assistant, nurse, medical assistant, physician, patient care assistant, to help with monitoring the patient and managing the manipulation of drainage containers, particularly if you expect to remove a large volume of fluid. Consider ultrasound guidance if available. Not only will it detect loculations or other challenges to a straightforward thoracentesis, but you can use it to mark the site for best access to the effusion for maximum drainage. Once you determine that thoracentesis is indicated and you have the appropriate labs, imaging, and informed consent, have the patient wear a hospital robe with the opening in the back to expose their posterior chest. Position the patient in the seated position if possible, with a table at chest height in front. The patient can lean on a pillow properly positioned on the table in front to expand the posterior rib spaces. Place the pulse oximeter on the patient's finger to provide continuous heart rate and saturation monitoring. Re-examine the patient's posterior chest by both percussion to identify dullness and auscultation to identify absent breath sounds. This indicates the level of the pleural effusion. Confirm the site that you plan to drain with the patient and the chest x-ray. Choose a spot 2 intercostal spaces beneath this level, 5 to 10 centimeters lateral to the spine, staying low in the costophrenic sulcus, but no lower than the 9th rib. Your puncture site should enter just above a rib to avoid intercostal vessel or nerve injury. Prepare your own sterile field and put on your gloves using sterile technique. Use the sterile prep solution to clean the site you intend to drain, as well as all surrounding skin, including at least the ipsilateral hemithorax and the spine, which can be used as a landmark. Place a sterile drape with a hole or sterile towels around your planned site of puncture. It is helpful to keep landmarks, such as the spine, in the field. Draw 3 to 8 cc's of 1% lidocaine into the 10 cc syringe. Use 1 to 1.5 cc's to numb the epidermis and dermis with a skin wheel using the 27 or 25 gauge needle. While waiting for the skin to anesthetize, connect your 18 gauge needle catheter to the 3-way stopcock and the 3-way stopcock to a 10 cc syringe. Also, connect one end of the pressure tubing to the 14 gauge plain needle for connecting to the vacuum-sealed container. Some types of pressure tubing have a roller attached through which you can control flow. If this is the case, slide the roller toward the sterile end of the tubing, away from the straight 14 gauge needle, so that you can maintain its sterility and control flow. Make a 1 millimeter small skin incision with an 11-blade scalpel in the anesthetized area. Now again take the 2-inch 22 gauge needle connected to the syringe with the remaining lidocaine. Numb the pleura for the patient's comfort. This can also help guide catheter placement. While slowly drawing back with gentle pressure, enter your skin incision site, aiming immediately above a rib. Continue to draw back as you advance. As soon as fluid freely flows into your catheter, you have entered the pleural space. Stop and pull back slowly just until the flow stops. This is the pleura itself, and you should place 2 to 3 cc's of 1% lidocaine directly into the space. You can repeat this maneuver to ensure adequate local anesthetic. Switch to the 18 gauge needle catheter and connect this to a fresh 10 cc syringe. Using the same tract you established for the pleural anesthetic, advance your 18 gauge slowly while drawing back on the syringe. Once fluid flows freely, trade the 10 cc syringe for a 30 or 60 cc syringe. Drain 30 to 60 cc's of fluid to be used for analysis. Send the collected specimens to the lab. Next, advance another 1 millimeter before pushing the catheter sheath into the pleural space. Draw the needle back as you advance the catheter. Aim the catheter to the dependent portion of the posterior costophrenic sulcus for maximum drainage. Do not bend the catheter over the rib, as it will kink and will not drain well. Hand the 14 gauge needle on the other end of the tubing to your assistant to place into a 1 liter vacuum sealed container. If you prepared the tubing with the roller piece properly, you can still control flow through the tubing with sterile technique even after you've handed the needle off. Open flow with the 3-way stopcock and the roller. Keep your finger on the roller in the event you need to stop flow abruptly. Allow the patient to drain. To maximize drainage, have the patient lean back posteriorly against your hand. If you notice air bubbles coming through, use the roller to stop flow. Tighten all connections and try again. If air bubbles persist, try switching containers, always stopping flow while exposing the end of the tubing to air to avoid pneumothorax. If bubbles still persist, stop the procedure and have the patient undergo a chest X-ray to rule out pneumothorax. Once flow stops, you may feel the sensation of the catheter suctioning against the chest wall and/or lung. Do not continue to suction for extended periods once you feel the space is drained. Even a soft catheter can induce parenchymal injury. To drain additional fluid, try to reposition the patient with even more of a posterior lean. If successful, you can repeat repositioning. However, if it no longer yields more fluid, the drainage is complete. Most pleural effusions are straw-colored. However, the color may vary from nearly clear to hemorrhagic. In the case of an unexpected finding of hemorrhagic effusion, ensure that the pleural space was properly entered and that the fluid does not represent procedure-related blood vessel injury. When the procedure is complete, turn the stopcock with the off position facing the patient and have the patient take a deep breath and perform a Valsalva maneuver. Have a sterile gauze and occlusive dressing ready for placement as you remove the needle and seal the puncture site swiftly but carefully. Obtain a chest X-ray to evaluate for adequate drainage and to rule out pneumothorax. Management of a small pneumothorax is possible with close observation, supplemental oxygen, and serial imaging. Large, expanding, or symptomatic pneumothorax may require thoracostomy. Management of pneumothorax is beyond the scope of this video. The clinician and patient should be aware of several risks associated with thoracentesis. Number 1, expansion pulmonary edema may occur with large volume drainage. To avoid this complication, it is generally recommended to avoid draining more than 1,500 cc's of fluid in one procedure. Number 2, bleeding, including hemothorax. Number 3, pneumothorax, including delayed pneumothorax. Number 4, infection, including empyema. Number 5, need for repeat thoracentesis due to inadequate drainage, loculation, or lack of definitive diagnosis. Number 6, reaction to lidocaine or other local anesthetic. Number 7, pain, numbness, cough, shortness of breath. And number 8, intra-abdominal puncture, visceral injury, particularly of the liver or spleen. To review, critical steps for thoracentesis are the following. Elicit key features of the history and physical that may predict difficult thoracentesis. Assemble equipment. Position patient properly. Prepare the site in the usual sterile fashion. After anesthetizing the local tissues, connect your stopcock and syringe. Enter the pleural space and administer additional anesthetic. Enter the same tract with the 18-gauge needle catheter while pulling back on the syringe. Once in the pleural space, advance the needle only 1 millimeter before advancing the catheter into the pleural space. Close the stopcock to the patient and using a larger syringe, draw off fluid for analysis. Close the stopcock to the patient once more and then attach the high-pressure drainage tubing to complete drainage of the pleural space. Once the space is drained, withdraw the catheter while the patient takes a deep breath and performs a Valsalva maneuver, and cover the exit site with an occlusive dressing. Obtain a follow-up chest X-ray to ensure the patient does not have a pneumothorax. Thank you for watching this Harrison's procedural video.